Good evening and welcome to our live telephone town hall event tonight with the Texas Medical Association. We are going to begin our conversation here shortly, and we're going to be discussing a variety of topics about issues and priorities facing medicine going into next year's session of the Texas Legislature, which will start in January of 2019. And so with that, it is with great pleasure that I introduce Dr. Jeffrey Apple, the Travis County Medical Society President. Dr. Apple, thank you so much for joining us this evening.
Thank you, Jason. Good evening, everyone, and welcome to this Texas Medical Association telephone town hall meeting on legislative priorities for medicine. As we approach the 2019 session of the Texas Legislature, which convenes in January. This is the fourth in a series of 5-area TeleTownhall TMA is hosting. At this time, it is my pleasure to welcome TMA President Dr. Doug Curran. Dr. Curran is a family physician with UT Health East Texas and Lakeland Medical Associates in Athens, Texas. He graduated from the University of Arkansas for Medical Sciences and completed his residency in Fort Worth. Dr. Curran has spent 42 years advocating for the patients and physicians of Texas. Welcome to Austin, Dr. Curran.
Thanks, Dr. Apple. It's always it's fun to come to Austin. It's fun to been here for football games and other things. It's always a good time when we can be together, and it's especially a good time as we're looking forward to our legislative session that's coming up in January. I think we have tremendous opportunity, and a lot of that has to do with the fact that physicians are really strong economic drivers in Texas. And we're going to be pointing that out, and we're going to be trying to work with our Texas Legislature to be sure that we help advance our issues to protect our patients and make sure that they're safe and as they're out seeking care, and that we're also able to economically support our practices. You know, physicians, there are 52,550 of us that take care of patients all the time, and we generate 670,000 jobs. And the average number of jobs that a physician creates is 13.1. The total annual output in Texas for physicians economically is $118 billion. And you know, that compares with higher education at about $10.98 billion, and legal services $43.5 billion, and home health at $22.4. So physicians are an enormous economic driver, and I think our political environment fosters that concern about where are we economically. I just recently visited with the Kaiser Foundation about that, and we'll talk more about that later. But it's great to be here in Austin with you.
Thank you, Dr. Curran. Next up is Dan Finch, the TMA Director of Legislative Affairs, acting as our traffic cop for the evening. Keep things moving for tonight's TMA TeleTown Hall on the 2019 legislative session. Dan?
Dr. Apple, thank you, and thank all of you for joining us for this TeleTown Hall. I'm actually more a train conductor than a traffic cop. My job is to make sure that the train runs on time. Let's move right into the discussion. Of course, the only thing that the legislature is absolutely required to do in their 140-day session is to pass a budget. And that budget drives everything, and it certainly drives health care, because health care, out of a biennial budget of about $210 billion, $70 billion, or a third of that budget is health care related, and the biggest portion of that is the Medicaid program. Medicaid is a continuing challenge for physicians and for the TMA, and tell us what we see on the horizon this session.
There's no doubt. You know, Medicaid always is an issue, and I think a lot of it is because people just don't understand what it does. It really takes care of the people that have tremendous need. And the vast majority of Medicaid is taking care of the elderly and the disabled. And about 30% or so is for pregnant women and children. So those are people that have to have care. We've got to do something with them. And, you know, in Medicaid for physicians, we haven't had any change in payment in 2 decades. And it's just not going to work anymore. We cannot continue to do what we're doing. Better off for me to give a patient $10 and send them to the emergency room. That's a better deal for me than seeing them in my office. So we just have to have some relief. And I think we know that if we can get reasonable payment, we move the patients from into an environment where they get much better care, much less costly care, and at the end of the day, we'll get better services and less cost for patients if physicians are paid fairly and properly in Medicaid. And so we're going to be asking for that in this next session. It's time to do that, and we're going to specifically ask for appropriate payment, and I think we begin with parity with Medicare. I think that we've got to have enough payment to do some good so that we can move people where they need to be.
In that regard, in the first 2 years of the Affordable Care Act, of course, the feds funded for primary care services a Medicare payment provision. It lasted only 2 years. How did physician participation in Medicaid improve over that time?
We saw a significant increase in physician participation, and I think we saw a lot of savings at the end of the day. We saw costs being placed in the right places, and as a result, money's being used more efficiently. And hopefully we'll see some return of that, and efficiencies will improve, and we'll see some savings, and it's not just going to be a big cost driver, but it should move us in the right direction to begin to pay appropriately for Medicaid.
Medicaid is almost exclusively in Texas now in a managed care environment, where the state cuts checks to the managed care companies, and they have contracts with you. What are some of the issues that are involved with managed care organizations and Medicaid?
Well, you know, Dan, we had a meeting this past Friday with the Medicare managed care organizations, and we really worked on some common ground that we could work on. And we talked about maternal health, and we agreed on all those issues. You know, I'd mentioned earlier I did an interview with the Kaiser Foundation, and they specifically asked why our maternal health issues are so inappropriate for a state where its economy is booming and jobs are at an all-time high, and that we're seeing really good things happen in our state, yet some of our healthcare outcomes are just not good. And we've got to get those better, and I think that the opportunity's there in this legislative session. I think that if we can provide good, accurate information to our lawmakers, they're going to make good decisions and move things in the right direction, and we'll see better payment and better access as a result of that, and that improved access is going to give us better outcomes.
Sure, and since you brought up maternal care, I mean, at least earlier this year, some of the data indicated that Texas had just an absolutely horrible maternal mortality rate, a mortality rate that was more emblematic of a third world country than it was. And yet, but that some of that data, upon further review, was not quite as bad. But that's not to say that it's really. But
it's still not good. We know that it's just not where it should be. Our state can do better, and we have to be sure that no mom goes without appropriate care, and no mother dies because we could have changed it if she'd had adequate access and appropriate care. So we've got to work really hard to be sure that happens.
Traditionally, 2/3 of the enrollees in the state's Medicaid program have been pregnant women and children.
Right.
And while over 55% of the births in the state of Texas are Medicaid, the babies are automatically covered, but the moms are enrolled for only a short period of time. And I think that cutoff is 60 days.
Right. That's correct. And in our meeting with the managed care organizations, they were all agreeable to going to a full year after a delivery. And we think that'll make an enormous difference in protecting our moms and making sure they get good care. It'll also give them a chance to get adequate birth control so that proper management can take place for the next pregnancy, and that makes for a safer, healthier mom. And that's what we want to do. We also, Dan, at that meeting we talked about credentialing, we talked about fair payment for different things and less prior approval. So those issues are all going to be on the table. We found the managed care organizations open to working with us, and we heard legislators at that meeting say they were excited we were working together, and they anticipate some real information coming out that they can work on. And we agreed to specific things about maternal health. All of our issues that came out of our maternal Congress back in March, those specific requests there were all agreed to by the managed care organizations, and they're out there now. So that gives the legislature something to work on to start with.
Of course, the credentialing process varies from plan to plan.
Absolutely.
The pre-authorization processes vary from plan to plan. So in your conversations with the managed care organizations, have
Yes.
we talked about standardization of processes?
Yes, absolutely.
Eventually.
All of those, standardizing those issues will be a huge plus. If we can get things standardized and you could have one place for all of the different managed care organizations. Right now, you have to, each one of them has its own plan. We just have a new pediatrician in our county, the only pediatrician in the county, and it's taken us the better part of 6 months to get her credentialed on all the different plans that are out there, and you can't do anything until she gets to that point, and they just won't pay you. So whatever she's doing now is she's just not getting paid for it, and that's not right.
Moving on to another area in the budget, one that we've been involved with for years and years, and with some success, is graduate medical education. And we continue to grow medical school enrollment. We're going to continue to grow medical schools. And I think it was last session we got the first legislative directive that we needed at a minimum 1.1 graduate residency, first-year residency training slot for every graduated medical student. Is this going to be another big issue for TMA in 2019?
Absolutely, Dan. You know that there are a number of medical schools coming online, and we got to be sure that there are enough residency training slots to make sure that those graduates that are coming out of the medical schools can train in Texas. Otherwise, we're wasting a bunch of the state's money. We're training medical students that are going away, and they train in New York or in California, and then they stay there rather than coming back. Dan, I'm a perfect example of that. I went to medical school at the University of Arkansas, and I came to Fort Worth and did my residency, and I practiced about 120 miles from Fort Worth. And that's what doctors do. They kind of stay around where they do their residency training. Yeah. So we've got to have that in Texas. We've got to have that 1.1 to 1 ratio, and we need to keep reminding our legislators of their responsibility to make that happen.
But we're going to add 3 new medical schools, University of Houston, Houston State, and TCU in Fort Worth. And the commitments need to be that, in addition to growing these medical school classes, we have to have residency training programs to train them. It's interesting that for at least a generation ago, we were saying, and it is as true today as it was then, that 80% of you stay within about 100 miles of where you train. So that has been consistent and probably will be so. We do have Dr. Cullington on the line with a question. Dr. Cullington, please ask your question, sir.
I deal with a lot of Medicaid patients, and the administrative, when you get a secondary Medicaid administrator, I get paid less money. So part of the people who are taking on the progress or take on Medicaid patients and be the administrator, they make money by increasing administrative costs, and they also decrease my amount of payment. So my question is, are we going to approach that problem? Because I think that some of the Medicaid management are not helping deliver care to the patient.
Oh, absolutely. We absolutely have to address those sort of people that are shaving money off on a regular basis. A transparency about how the money is spent and an accountability has to be forthcoming. And we're going to push really hard on the legislature to be sure that happens. We need appropriate people at HHS so that they are able to make sure that these managed care companies do what they're supposed to do, and that we get appropriate funding. There's really clarity about how the money is spent and where it's spent. So we'll be working really hard to make that happen. They don't even have a medical director right now. So we have to get some physician over there that's kind of can be supervising, monitoring, and making sure things happen. And we're working hard on that already. Some of those administrative things we can work on now. And we have a new HHS director, and so we'll try to work with that person to get some clarity and some fairness back in the system.
Great. Let's leave this discussion for a second, and I'll ask Jason to read the first poll question. Jason?
We would like to know, which do you believe Texas must prioritize to build a physician workforce? Press 1 on your telephone keypad if you believe it's more medical school capacity. Press 2 for more GME capacity. Press 3 for both. Press 4 on your telephone keypad for neither. And press 5 if you're unsure. Back to you, Dan.
Thank you, Jason. Appreciate it. And while we're waiting for those numbers and for your responses to come in, let me go for a second. The legislature, we're getting ready to elect the next Texas legislature in a couple of weeks, and I'm honored to introduce to you Dr. Dave Flieger from Austin, who is president-elect of the TMA. He is a Travis County Medical Society leader and TexPAC leader, and let him give an overview of the politics of the election that comes up in just a couple of weeks.
Well, thanks, Dan. I think a couple things that everyone should know. The first is that TexPAC is our TMA Political Action Committee. Hopefully everybody knows that. What they may not know is that we involve ourselves in statewide and local elections because, of course, all politics is local. So what we're trying to do is get our physicians involved in the political campaigns of our politicians by walking the block or putting signs out and, of course, getting financially involved. If TexPAC can have an influence on our local politics, then medicine is successful. If medicine's successful, then our practices do better and our patients do better. And that's the end goal. And of course, right now we're in the beginning of our election process. First day of election was today, and that runs through November 2nd for early election, and then, of course, election day is November 6th. So it'll be interesting to see how that comes out. Our prediction would be that as far as the Texas House and Senate, you can't predict them, but the first thing would be that the Senate will no doubt remain strongly Republican majority. As far as the House is concerned, the Democrats will probably pick up from 5 to 10 seats, and that being the case, the Republicans will still have a large majority. So welcome to Texas. Either way, TexPAC has supported physicians of both parties, and that's the way we work. We support people that support medicine, and that happens to be candidates on both sides of the aisle. So as long as they're good with our issues, we're good with them. And, of course, everyone should be, actually, last Friday, you should have gotten an email list of the endorsed candidates from TexPAC. That will go out a couple more times if you haven't gotten that. So take that to the polls with you, give that to your family and friends, and support the House of Medicine. And by supporting medicine, you're helping your practice, you're helping your patients. So I'd ask everybody to get involved in TexPAC. We need your membership, we need your dollars, we need your influence. We hope that we can count on you when you join, re-up your TMA membership, that you will also add TexPAC membership to it.
Dr. Flieger, thank you very much. And if you don't have the list of endorsed candidates from TexPAC, the Party of Medicine, you can find it at www.texpac.org. Let's go back and talk about the poll results. Interesting, and they've so far varied a little bit from city to city, from San Antonio to Houston to Austin. Almost half of you believe that medical education, that growing the physician workforce is going to be done by growing GME capacity. 25%, 23% say both GME and medical school capacity, and then decreasing amount. So interesting that you feel so much more strongly about growing GME capacity.
Yeah, I think that's an A+ for the Travis group and the region, don't you think?
They're actually
they're getting it.
The first ones that were correct.
Absolutely, that's right. I think they're getting it.
Let's talk about insurance issues, because we talk about budget, and then next down the list we always have a lot of the same issues in Medicaid play over on insurance issues for us. And we've seen in the last several sessions attempts to do away with physicians' ability to balance bill in out-of-network situations. We have raised issues related to the network adequacy, as we see networks contracting all the time. And then just this year, Blue Cross announced that it would retroactively deny emergency payments for patients if they determined in their HMO plans, if they determined that after the fact that it was in fact not an emergency. And so
Well, you know, Dan, payment just continues to be so confusing, I think, for our people, all of our patients. They struggle with the bills they get and the bills they get from multiple physicians, the bills they get from hospital facilities, and all of them. This lack of transparency is very frustrating for our people. So I think we've got to get some clarity, and we really have to do something about network adequacy. You're exactly right. I mean, you squeeze down those networks, you make people less available, and you push some of the costs back on them, and they can't get adequate care. And the supervision of that continues to be a problem, and I think we're going to have to deal with that as well. And you want a major disaster, just do away with balance billing. If we cannot do that, then the insurance companies can do whatever they want, and they can force you into all kinds of circumstances that you may not like at all, and networks could even become more narrow and more difficult to get care. Those are all issues that limit access to care. And we know that access to care at the end of the day is going to make patients less likely to get the care they need. And certainly if a patient is worried about getting charged for an emergency room visit, they may be less likely to go and stay at home when they really need emergent care. And you know, Dan, we've had huge issues with telemedicine. We passed a bill, as you know. You worked hard on that bill to get the things we needed from in telemedicine so that we could get fair payment for everybody, not just a telemedicine company, but a physician who's taking care of a patient on the phone or through a computer system. And we're even seeing Medicare pay for a lot of those, especially in underserved areas, but we're not getting any payment at all from our insurance companies. We got to have some responsibility in some areas. It just seems like they can sandbag everything and get away with it. So I think we have great opportunity during this session to shine a light on some of their behaviors and hopefully see some real changes.
Yeah, and you bring up telemedicine, and you were intimately involved with that effort as well. And we did some fairly fundamental things in order to recast a regulatory scheme for telemedicine in Texas. Number one, we said it is the practice of medicine. So you have to be licensed in the state if you're going to take care of Texas patients. Number two, we said that it is not a different standard of care. It's not a higher standard of care. It's not a lower standard of care. It is, in fact, the same standard of care for inpatient care, and that's specifically in the legislation. And the third thing that we said was that with regard to that the plans could not discriminate in the payment for a covered service, whether that service was paid for, provided in person or via telemedicine. And what we're pushing there is really two concepts. Number one, telemedicine is a tool. It's a tool in your toolbox to take care of your patients. And therefore, and it really boils down to this simple phrase. A covered service provided to an enrolled patient by a contracted physician should be paid for, period. Telemedicine is a tool. It is simply a means of providing the service. The plans want to treat it as a service itself. And as they continue to do that, then they are free to bundle up that service and contract it out. That actually has the effect of driving people away from their own physicians, and we want to return telemedicine to my doctors and your patients' doctors, so that they're not driven away to another company.
Yeah, and we know that's a lot more cost efficient. At the end of the day, the patient will get much better care, and they'll be in a better place because they've had a consistent management of their problem.
Yeah.
And I think too that we know, especially with balanced billing, that patients understand the struggles, and that those struggles really should be laying at the feet of insurance companies. They have to help us figure out how to do this fairly, and they need to provide adequate networks and adequate opportunities for patients so that they're not being balance billed.
No, and I think your point that to the degree we continue to narrow these networks of physicians, then we raise the opportunities for folks to be out of network when receiving care. We raise the specter of additional balance billing issues, and we've seen time and time again efforts in the legislature to take the patient out of this. And actually the patient is crucial to this, because the patient has the contract with the insurance company. You don't have the contract with the insurance company when you're out of network, and the patient has a relationship with you, and their involvement in the mediation process is absolutely critical to its success.
the patients are kind of being dumped on, we would call that in our business a inappropriate transfer of care, you know, and we'd get in trouble for doing that, Dan, but insurance companies can get away with it.
Well, guidelines versus ethics, Doctor. I want to get back to the issue of pre-authorization, and that in the last couple of years has been just an enormous burden on physicians, and not just in the Medicaid program, but in the commercial market as well.
Dan, as I've traveled around, one of the biggest problems I hear coming from physicians is this enormous administrative burden that we have to deal with. I mean, I've had to prior approve albuterol. It's just nuts. You know, some of the stuff they ask for just makes absolutely no sense. And it's designed really to hassle rather than to facilitate good care and good quality. And so I think we have to deal with prior authorization and administrative burden issues in this legislative session. In some places, it's been a bigger concern than payment. But I think those are probably our two biggest priorities, to improve payment and to get a better circumstance for prior authorizations and referrals and other hassles that just keep coming our way. Administrative burden has to go away. And I think we are also in a political environment that should be very receptive to that. It doesn't cost a lot of money, and they understand if you want to run a good business, and we talked about the economics to begin with, we're trying to be fair and honorable. We don't need all these administrative hassles on top of it. Keeps us from doing our job.
Let's move on, and Jason, I'll ask you to ask the second polling question tonight on telemedicine.
Thank you, Dan. Our second question is, do you currently or will you use telemedicine in your practice to care for patients? Press 1 on your telephone keypad if you do use telemedicine. Press 2 on your telephone keypad if you do not. Press 3 if you plan to. Press 4 if you do not plan to. And press 5 if you're unsure.
Right.
Back to you.
Thank you. Thank you very much. And while we're waiting for your responses to come in, I believe Dr. Jason Turk from Fort Worth is on the line. Dr. Turk is a pediatrician and chairs the TMA's Council on Legislation, and will end up spending many sleepless nights in the next 140 days of 2019. Dr. Turk, are you there?
Yes, I am, and you're absolutely right. There are going to be plenty of wee hours of the morning and late nights coming up for us. It is a 140-day marathon that's run at a sprint's pace, and as usual, we're going to be seeing more than 7,000 bills and resolutions introduced in the session, with about one-third of these dealing in some way, big or small, with health care. Like it or not, the legislature's effect on our practices and our patients is really immense. If you are not at the table, then you are certainly on the menu, and I assure you TMA is going to be present and heard from to defend what needs to be defended and to advance the cause of our patients and the physicians who care for them. While the Senate and its presiding officer, Lieutenant Governor Dan Patrick, look to return with a supermajority in 2019, the same cannot be said about the House of Representatives. First, the House must elect a new speaker. While that has been the subject of great discussion around the state, it also means we will have new committee chairs, new committee members, and new committee staff to hire. So while we expect the Senate to quickly begin its work, it's going to be some time before the House infrastructure is in place, which will act as a speed bump for at least the first month of session. But at the end of the day, the legislature has only one must-pass bill, and that's the state's budget. Typically, that process takes the entire session to iron out, and many other bills are often held hostage by one chamber to pass its version of the budget. Maybe this is the year that they'll only pass one bill, but I certainly wouldn't count on that. Finally, I think it's really important to thank the other 17 members representing both primary care and specialty care on the TMA Council on Legislation and the incredible lobby staff of the TMA. This really is a hard-working group, and they spend countless hours looking at and developing the best approaches to our issues. If any of you have any questions about a specific issue, please reach out to one of the members of the Council. Thank you.
Great. Thank you, Dr. Turk. Appreciate you joining us tonight. Back to the question on, do you currently or will you use telemedicine in your practice? Interesting, it never ceases to amaze me how different responses we get from around the state. Nearly 20% of you, 19%, say that you are currently offering telemedicine services, and another 30% of you plan to, and I presume that would be in the near future, although that wasn't part of the question. So there you go. 50% of the doctors in the Travis County area are 20% offering it and 30% planning to. It's rather interesting. Dr. Kern, on our letterhead, it says Texas Medical Association, Physicians Caring for Texas. And so public health is always a huge issue for us in every session. Sometimes it's more politically viable than in other sessions, but it's always a very important issue for us. Yep. Issues from vaccines to emergency preparedness to just general public health.
Well, Dan, it's amazing to me how much volatility can come out of things that should just be white hat issues for us that make us all better. And I'm just amazed at some of the things we get into. And as you know, we've seen a significant force rise up in the anti-vaccine area, and we've had to push really hard because, vaccines are just strategic. If you really look at what's made a difference in our healthcare system, it's probably clean water, which I understand you all are struggling with here in Austin right at the moment, but clean water and just appropriate sanitation and vaccinations.
Right.
They really it just makes an enormous difference. TMA working with some other for the Texas Public Health Coalition,
right.
Did a survey and found out that Texas Republicans overwhelmingly supported vaccination laws, and I think that's really good for our lawmakers to know that. We found out that 86% of Republicans that vote support the current laws requiring children to be immunized to attend public schools. So to have that in place and to have that knowledge is huge for changing some of the attitudes, I hope, of legislators that may question the value of vaccinations. Their constituency obviously does see the value of vaccinations, so we want to be sure we're carrying that message to them. And we see the value. More important than anything else is the value that comes from the physicians who are caring, and we're well aware of the significant improvement in outcomes when children are vaccinated, when adults are appropriately vaccinated. Makes an enormous difference.
But we're still in an era where the ability to opt out of a vaccination is growing. No. Despite the safety of the vaccination, despite the effectiveness of the vaccination, people continue to opt out. Last session we worked hard on a bill that would allow school districts, or actually require school districts, to release by campus aggregate numbers on the percentage of students who are immunized versus the percentage of students who are not, so that not to release, obviously, the individuals, the identity of those who were or were not vaccinated, but to give parents a source of information that they could evaluate in terms of the relative safety and what they wanted to do.
Well, we're going to take, for TMA, vaccinations are going to be at the top of our list, and I think that we'll be successful in warding off any limitations in vaccinations. I think we'll continue to be very supportive and see positive things come out of that. Dan, I got a little late start coming to Austin for this particular visit, and I got that because I was spending time with a family that I've cared for a long time, and one of the family members was dying, and we got to move from a time where we kind of look at dying as a disease to rather dying as just a natural process sometimes. That this lady's in her 90s and at the end of life with multi-organ system failure, and spending a little time as a physician at the bedside and loving on that family is really strategic. But, we have lots of roadblocks that we have to deal with every year about how do we continue to take really appropriate care of our patients. How do we manage them properly at end of life? And we'll have those issues again this year. And we're going to meet them head on and do everything we can to be sure that our patients get proper care and get the right things happening at their end of life, that they can choose what they want to happen and the right things happen for them. Our current system is pretty cumbersome, and we got to clean that up some. We avoided in the last session a disaster and a potential where we couldn't take the kind of care of our patients that we wanted to, but we were able to abort that, and we have to move forward with positive things in this next session and get the right thing done for our people.
Sure, and it is a growing and emotional issue in the legislature. It was last session. It certainly will be this year, both the use of advanced directives and I know that there have been calls to expand medical powers of attorney to not just the closest family member, but to almost virtually any family member, which would make end-of-life care and those very, very sensitive and personal decisions that much harder at end of life.
And we just want to be sure everybody's protected so they can do what they need to do and what they want to do, so it's fair for everybody.
Again, if you have questions of Dr. Curran, please press 0 on the phone. That'll put you in the question queue. And while you're contemplating that, let me move on to, there is just a whole raft of issues related to licensure, to the Texas Medical Board will once again be up for a sunset review. It's Groundhog's Day all over again for that bill, since, but it is what it is. There are still a great number of improvements that need to be made just to the agency itself and the fairness and transparency of its processes. But one of the issues that we have talked about is a very expedited licensing process, because the licensing process generally is complex, it's complicated, and it takes a fair amount of time. And
right.
Even though you have a statutory limit of licensing a new physician within 51 days of receiving the clean and complete application form, it's assembling the documentation for that application form that is so time-consuming.
Right. Well, I think we're going to have to work on a lot of things with the Texas Medical Board, and we're doing that even as we speak. We have met with them on a regular basis. I had the privilege of meeting with the executive director and some other attorneys over a number of issues that affect our physicians at the medical board. And we know that the sunsetting of the Medical Practice Act is strategic, and it's going to be very important. And as Dr. Flieger and Dr. Trek and others have mentioned, relationships really are important in politics. And I have the privilege of having my senator as the vice chair of Sunset Commission, and he has indicated an interest in helping us get things moved along with the Texas Medical Bill and get that happening early. And I know in conversations we had with the Lieutenant Governor, he felt like that should move forward early this time. So I think we're going to get the medical board on a good course early, but we want to have our ducks in a row to be sure things happen right with appropriate physician relationships, so that
Sure.
docs can work with the board, can be sure that if they're seeking a new license in Texas, that can happen in a prompt and appropriate way, especially if they have a clean, no issues license in other states. That ought to happen very quickly. And we have to figure out how to make that happen. And I know the conversations and the time I've spent with the medical board personnel that are all a number relatively new, as you know, and they've been positive. They've been good times. So they're a challenge, but we're going to work with them and try to get them moving in the right direction, so patients receive fairness, or so physicians receive fairness and transparency as they deal with the processes of the Texas Medical Board.
For the last two sessions, we considered legislation, as you recall, called the Compact for Interstate Licensure, which would have authorized Texas to join a national licensure compact, and for the purpose of really expediting the licensing of physicians among the member organizations of that compact. And for any number of reasons, though, the legislature didn't see the benefit of joining the compact, primarily because there were allegations that it was simply giving away Texas's responsibilities to run its own thorough licensing process for physicians, and yet, and so that took away some of the ability for us to really recruit out-of-state physicians. And so what I think that the conversations we've had with members of the Texas Medical Board on the issue of expedited licensure is to go pretty much to the compact's requirements for an automatic licensure, and that is a physician who is in good standing with in his current state, has not had a disciplinary action entered against him, is currently board certified. And I want to make sure that you understand, currently board certified does not mean maintaining that certification, but currently board certified at the time of licensure. And to the degree that everything is in order, that we ought to be able in Texas to give that individual a license in a very quick and expeditious manner and circumvent so much of the paperwork involved in licensure.
Well, we know, Dan, that we're still an underserved state as far as physicians go. We know that we rank 47th in primary care physicians per 100,000. So we need docs in our state. We need good docs. We all agree with that. And so moving them forward in a positive way is really important. And I think we want to do everything we can to facilitate the medical board making a rapid and fair decision for physicians that have uncomplicated licenses.
The other issue that we took to the legislature last year and will again this year is the idea of as practices change, and there's no doubt there's been over the last number of years been a sea change in physician employment by hospital-run organizations or other large multi-specialty or single-specialty groups, but employment has become simply another way of compensating physicians for professional services. And yet, to the degree that organizations that that are nonprofit healthcare corporations, organized by hospitals, to the degree that physicians feel that they are that their practice and independent judgment, medical judgment, is affected by policies or acts, there needs to be a good way to address some of those complaints and concerns.
Well, there's no doubt about that, and I think it's an issue we'll have to look at in this particular session. The corporate practice of medicine is illegal in Texas, yet I've had a number of physicians ask me about how did they push back when they're told that they would like for the physician to be ordering certain tests or doing certain things. And, that's my colleagues in emergency medicine, my colleagues in family medicine, and so forth. I see it in lots of areas, and I'm not saying that happens everywhere, but I think it is a problem in some places. And as a result of that, we need fairness. We need to be sure that physicians are autonomous clinically. They can do whatever they need to do to take care of their patient, and it should not be scripted as to how they manage a patient. They should be able to do that independently, and we don't want cost drivers to be generated through physician behavior that's encouraged by or empowered by corporate America. That's just not good care.
No.
We want to be able to do what's right for the patient.
And the bill that we had last year, last session, which will be introduced again this session, would park that responsibility with the Texas Medical Board. And it would put it there for the specific reason that it is the medical board that must certify these nonprofit healthcare corporations before they can proceed with business. And since the medical board is involved in their certification, then clearly there ought to be some process to adjudicate these sorts of issues in a fairly reasonable way, in a reasonable manner, but to give physicians the opportunity to air those problems and complaints.
Yep, absolutely. And Dan, we always have scope of practice issues. They're going to be there.
You're interviewing me.
Yeah, I'm interviewing you now. But we see all those, and I'm convinced, my grandkids and great-grandkids and great-great-grandkids will be having to deal with people who want to practice medicine without appropriate training. And I think a team-based care is great. We have nurse practitioners I work with. I have a couple of PAs I work with, and they are fabulous. They absolutely facilitate good, high-quality care for our patients. But it needs to be in the right environment, in the right circumstance, and team-based care is just the way to go. And I think that team includes a lot of our nursing staff and our scribes and other people that are assisting us in caring for people. When we have that kind of attitude, I think it really facilitates good patient care. So I hope that we don't have too much of a fight over scope issues, but they're here every year, and we'll be prepared to deal with them when they come.
As regularly as the sun comes up in the morning.
That's correct. Yes, sir.
Face. And you were intimately involved in 2013 when we had an agreed-to bill with nurse practitioners and the PAs with regard to the delegation of prescription authority. And I think you were even involved in that hot August day in 2012 when we sat up here at the TMA building and asked physicians to define your core principle. And it really didn't take long for you to do that. And the core principle that you all defined that day was that independent diagnosing and prescribing is the practice of medicine. Physicians can delegate but must supervise because ultimately physicians are accountable. And that position, that core principle has not changed. And when we talk about team care, it is by definition a physician-led team. But it is a team that has its various members bringing their substantial skill sets to patient care. And it's your job to make sure that the right patient is seen by the right member of your practice team. And it's worked out quite well.
It has. It makes our patients, I think, much better. It provides them much better care, and it empowers them. It facilitates access as well. And
when we had in 2013, when we met with the nurse practitioners, and we'll meet with them again in very short order. Our core principle has not been the same, but it has not changed in the least. But it is such that we cannot and we will not back away from our core principle, but everything else is open to discussion. What will help make a more collaborative practice for you and to better take care of your patients? The other issue that has been so significant in 2017 and will be again in 2019 is the whole issue of opioids and the opioid crisis. Number one, we are not West Virginia, but that does not mean we do not have a problem.
Correct.
And so, and at the very beginning of last session, it was very clear that I should preface this to say that for 3 sessions we worked to move the prescription drug monitoring program, which is over at the Department of Public Safety, a law enforcement agency, over to the Board of Pharmacy, and we accomplished that in 2015. And the idea was that we wanted to make it a good clinical tool for physicians to use. And then, of course, the opioid crisis has been growing over the last number of years. Last session, members of the legislature wanted to mandate that you check the prescription drug monitoring program for every prescription for every controlled substance. And that would have been effective in September of 2017. As it turned out, because of the involvement of TMA and others, number one, the mandate was limited only to opioids, barbiturates, benzodiazepines, and carosperidol, 4 drug classes. And the deadline for the mandate was pushed off until September 1 of 2019.
Right. Yeah, we've worked hard on this, as you know, and I want to preface a lot of our comments in the sense that I think as physicians, one of the greatest privileges we have is to relieve pain. And we should do that. We really need to care for our patients. And if they need pain relief and it's appropriate, we should administer that. We should do whatever it takes to do that. I'm not sure there's anybody else who has that great privilege that we have to do that. So I don't think we ought to get things out of focus. We ought to be taking care of our patients and making sure they have appropriate pain management, but they ought to be managed properly. And we've seen things that have gotten out of hand, and we must be responsible in doing that. So I think fixing our prescription drug monitoring program is really strategic, and somehow getting we have until 19 to get this done. We specifically got this done so we could work on it during this session. So we want an electronic fix.
Yeah.
And I feel like that we're at a point where we're going to get that. I hear from leadership, especially in the Senate, that they want to help us facilitate that. And conversations have been that we'll get that where it comes into your electronic record or comes by email, rather than us having to look up everything on the prescription drug monitoring program. And I think we really want to work hard to get that done. But as we're working on this, I don't want us to withhold pain treatment for the patient who needs appropriate pain treatment. And we're seeing some difficulties out there now. We've seen Walmart and others say that we're not given but just so many days of pain medication, and I think that's practicing medicine. They have no business and no right doing that, and we're pushing back on them. And I know we have friends at the medical board that are also pushing on them, and we're pleased about that.
I think very soon we're going to see some sort of meeting, some sort of come together of the medical board and the pharmacy board to iron this out. The large problem is a physician may write a 10-day supply of pain meds for a surgical procedure because in that physician's experience, that's what the patient is going to need in order to recover. That is, 10 days. It's not 30 days and 2 refills. It's 10 days, period. And now we're seeing corporate policies from some of the pharmacy units, like Walmart specifically, saying that we are not going to fill for longer than 7 days. And so that means on day 8, 9, and 10, the patient is without medication and is coming back to your office for another prescription, but they're also then going back to the pharmacy for another copay as well. So there are a lot of issues involved here, and I think that the TMA pushing and supporting some position and intervention by the medical board with the pharmacy board is certainly appropriate. As for next session, I know that we're going to be pushing, number one, for the full electronic integration of this prescription monitoring program with EMR systems. That's good. We're also going to see if we can ease into these mandates by limiting the mandated check on these 4 drug classes, initially to Schedule 2.
And I think, Dan, the other thing that I learned a lot about when I was in Laredo, talking with some DEA folk at a medical society meeting with the drug take-back program was really important.
Very important.
And it's exciting to see that happening. I know it's happening in Athens, my hometown, so we need to see that happen too.
As usual, we could talk about this for much longer than your 1 hour of CME. We do have a physician on the line and I think it's appropriate to sort of end on this question regarding the future of private practice. Dr. Abakhalid, are you still on the line, sir?
I sure am. Thanks for taking my question. You were beginning to touch on this a couple minutes ago, but I feel like one of the biggest threats to our profession is the disappearance of private practice. And I saw a statistic recently that said for the first time, more than 50% of physicians are employed for the first time ever. As a physician in private practice for over 20 years, I know it's just gotten harder and more complicated to run my practice. And I just wonder what the TMA's view is on that, and if there is interest in protecting private practice as it is.
Well, let me tell you, I'm a private practicing physician. I've been in private practice for 39 years, and I'm with you. It is a tough time, but we are absolutely committed to maintaining the private practice of medicine. That option needs to be available for every doctor out there. We'll do whatever we have to do to make that happen, and I'm going to do everything I can to represent you well so that physicians have options. They can be employed if they want to, but they can stay in private practice if they want to. But it's a challenge. Help us. Let us know what we can do to make your practice better. There are lots of things here at TMA available to you. Thanks for your question.
Yes, thank you so much. And Dr. Curran, thank you. This hour, again, has gone by far too fast, and we've touched on far too little, but we'll have an opportunity to do better. Dr. Apple, thanks to you for hosting us. Dr. Flieger, thank you for joining us, and thanks to the Travis County Medical Society for sponsoring this call. If you're on the line and have a question that you didn't get a chance to ask, call the TMA Knowledge Center at 1-800-880-7955 or email us at knowledge, KNOWLEDGE, at texmed.org. So Jason, I'll let you pitch the final CME question to our listeners, and we will thank you and the TeleTown Hall people for helping us with this evening. Thank you very much.
Thank you so much for that, Dan. Your final polling question of the evening for your CME is, are you going to implement any new strategies based on what you learned in this call? And if so, which ones? Press 1 for attend TMA's first Tuesdays at the Capitol Lobby Days this session. Press 2 for sign up for TMA Legislative News Hotline email reports. Press 3 for respond to TMA Legislative Action Alerts. Press 4 for write, call, or speak to legislators. And press 5 for more than one of the above. I'd like to thank everybody for joining us on this live telephone town hall with the Texas Medical Association. Again, if you have a question or a comment on this forum at the end of this call here shortly, you're going to have an opportunity to leave a voicemail, and all voicemails will be forwarded on to the Texas Medical Association. Just please leave your first and last name and some viable point of contact, either a valid email address or a working telephone number. And with that, I bid everybody a fine evening and good night.